I think a lot of these alternative payment models have specific requirements that engender certain aspects of patient-centeredness. For example, the OCM requires a care plan, 13 points documenting the treatment, the goals, the expected response, which is to be provided to that patient to ensure they have a document that they can understand in patient-centered language. There are quality measures around patient satisfaction, shared decision-making, such as percentages of advanced care plans documented. Again, these are specific aspects, certainly not the whole picture. And I think to get to the whole picture and really making the patient at the center of it, turns into how the patient is really a central piece of physicians taking on risk. So patients knowing where to call when they're having trouble, patients really engaged and educated about their care. There aren't as many specific requirements around that, and I think practices together are going to come up with the solution on how best to engage them, whether that's through text messages or apps or phone calls or programs and other ways to really engage them in that care with the ultimate shared goal of avoiding an unnecessary hospitalization or an unnecessary kind of decrement in their health. But that piece of shared savings and whatnot is a lot more nebulous than percentage of patients getting X or percentage of patients getting Y.
Yeah. I mean, I would argue that the biggest potential way of managing a lot of the risk of these patients is just keeping them out of the hospital. And so no matter your flavor of alternative payment method, that choice of trying to keep patients out of the hospital is going to be front and center of any practice doing this in the next 5 years.
Yeah, I agree. I'd like to supplement it in that we've had enough experience now where we've been able to change the behaviors of payers because of the level of data that we're able to acquire. And that is, you know, the biggest tragedy is someone not getting the right care, having the wrong outcome, and believe it or not, it actually costs more money. So we've been able to change, without getting into specific details, reimbursement policies of major payers, because by spending a little bit of money up front, they get a 10x return downstream. And in one example, women are found to not need chemotherapy who were getting it, now they don't. And in another example, people were getting very toxic medications when they could get very less toxic and highly more effective medications and live 4 times longer. So my personal view as a practicing cancer doctor and as a researcher is that this is a wonderful transition from just anarchy, where variance reigns, to reining in variance, but then moving to precision. You know, the president deserves a lot of credit for the emphasis he put on precision medicine. And precision medicine, when you think about solving the N of 1 problem, population health is you do the same thing pretty much for a big population, not accounting for the variability person to person, and you get it about 80% of the time right. Precision medicine, if you're really good at it, you get it right all the time, and then you add it all up, and you have the N of 1 problem solved, but yet you've done the same thing as you try to do in population health. So what's going to change this entire dialogue, and it's going to make regulators and payers crazy, is that we're just starting to get our head around all the things we just talked about, and it's going to move to the right again with immuno-oncology, genomics, proteomics, and other things. So it's, you know, it's just an incredible time. Now let's jump back over to Dr. Sagar and get her take.
Are existing APMs patient-centered or not? Definitely. I think we've all gotten away from it with the fee-for-service world, with the IOM report coming out and talking about how disjointed care has been. I think a lot of us have taken a look at that and wanted to bring the patient back to the center, trying to make sure that care is integrated and coordinated completely. It's not just about getting evidence-based medicine, although that is a huge component of it. We want to make sure that patients are getting NCCN guidelines based approach for their treatments as much as possible. There might be variations, we understand that, but for the most part, we want to focus on evidence-based medicine. We also want to make sure that the patient's voice is heard. as much as possible. Our model, we've tried to keep it as simple as possible for a reason. We don't want to mandate too many things. We don't want to regulate too many things. We want to give the provider a certain amount of freedom to be able to take care of their patient as well as they can. So the whole model is centered around the patient, but we want to encourage that physician-patient interaction and build on that relationship.